All right, so I'm Erica Dolph, and I was in the NICU for this whole thing. And I was with Dr. Hawk, and I did my project on hypoglycemia and glucose homeostasis in infants. And so pretty much hypoglycemia is low blood pressure, and it's really common in infants because they're at a high risk because their mom has been giving them glucose, and then once they are born, they have to start producing it on their own. And so a lot of times there's some problems with that, and like especially right after they're born, they have a lot of problems with hypoglycemia. And so a recent journal by the American Academy of Pediatrics outlined new standards in risk stratification and when to test newborns and what hypoglycemia was considered. And so those infants who are at especially high risk are the small infants, and that's because they don't have adequate stores of glucose because they're so small. And then infants that are less than 36 weeks of gestation because they aren't developed enough to produce it on their own. And then the infants at a medium risk are the large ones, and that's mostly because it's hard to rule out diabetes or borderline diabetic because the moms normally have that. And then infants of a diabetic mother have problems because when their mom is producing they're producing a lot of glucose, and so they have a lot of insulin. So the baby's getting a lot of glucose and producing a lot of insulin, but when their glucose is cut off, they still have a ton of insulin. And so their glucose is in short supply, so they become hypoglycemic. And so due to the facts outlined in this, St. Elizabeth changed its policy regarding glucose testing, and they now only test infants who are at risk or showing signs of hypoglycemia, as opposed to before they tested at 30 minutes of life and 2 hours of life regardless. And so through this, I wanted to compare and contrast before they changed their policy and afterwards and see if it's beneficial. And so people who helped me with this were the people in HIM, helped to create my auditing account so I had access to all the patient files. And the lab gave me lots of information on glucose testing and the benefits of the policy for them. And then Grant Orley over in the NEAR Center, he was a statistician who helped analyze the data, and Paul Edwards actually helped set that up for us, so that was really nice. And Dr. Hawk was essential. She helped me through the whole thing. And so first we just collected all the data for the over 600 babies in the 2 different eras. And so era 1 was all the infants in March and February, and then era 2 was April and May. And so we collected the gestational age, the mother's history of diabetes, the birth weight, the number of bedside and serum glucoses, and then the number of glucoses that were hypoglycemic, which is below 45, and then whether they were transferred to the NICU or not. And so then we determined whether they were large or small for their gestational age, and then we determined their risk factor. And so SGA infants or infants less than 36 weeks were at a high risk, so we classified them as a 2. And then large infants or infants of diabetic mothers were at a medium risk, so we classified them as a 1. And then we collected this data and charted it, and then we went to the statistician and they helped us analyze it. And so for the results, in risk stratification, in the 2 eras, there was not a significant change between the stratification of the patients. There was about the same in each era. There were a lot of babies in May, but the stratification of the different risk categories was still the same. And so we had similar data to compare, so that's good. And so for the number of glucoses performed, the total number of glucose tests went down by over 50%, and the average glucoses per patient had significant differences in the no risk and the high risk category. And in the high risk category, the number of glucose tests actually went up, and the number in the no risk category went down, and in the low risk there was not a significant change. And so in the number of glucoses below 45, there was not a big change in the low risk, but in the no risk there was a huge change, and in the high risk there was a huge change too. And we attributed the huge change in the no risk policy because they changed their policy to they fed the babies before they tested their glucose levels, and so that helps a lot because they had nutrition in them and they could produce their own glucose, and so that would be why there's such a huge difference in the no risk category. And so for the percent admitted to the NICU, there was a significant change, and it actually went up in era 2, which really bothered me and Dr. Hawk because we don't want a policy that admits more babies to the NICU. So we went through and we looked at every single baby that we had recorded that they went to the NICU, and most of them in era 2 went there for respiratory problems, and so it was not actually, it didn't go up for hypoglycemia. And so overall, the new glucose management helped the hospital a lot. Most importantly, it decreased the hypoglycemia amounts, and it more clearly identified the patients that were at risk. And so that means that they could focus on the patients that really needed help and not cause stress for the other patients. And so another benefit that benefited the hospital was the cost. The serum and a bedside both cost about $1.50, and just from the reduced number of glucose tests, the expenses went way down. The cost of all the tests in era 1 was $1,374, and in era 2 it was $664, and so that's like in half. And also it cut down on the workload of the lab by a lot because they weren't doing all these glucose tests. And then a less tangible effect was the effect on the families and the kids, because the babies were not being like poked in the heel, which they don't like, and so it caused less stress for the parents, and they could just be together for the people that didn't have problems. Then the ones that were at high risk, they got the extra care they deserved, and they got the extra attention they needed. And so in conclusion, though the data of the NICU transfers looks like the policy was unsuccessful, there were actually more admissions in era 2 for respiratory diseases than there were for era 1. And so overall, there were actually 5 cases of hypoglycemic infants admitted to the NICU in era 1, and then only 2 in era 2. And so there's a huge difference between the ones admitted for hypoglycemia, which means that the policy was actually successful. And so this new policy does a better job at identifying the infants who are at risk for hypoglycemia and treating them accordingly. And it makes it easier to only treat the ones that have the problems. And it puts less stress on the healthy infants and gives them the attention they need. So altogether, it resulted in less NICU transfers and less cases of hypoglycemia. Yep, the end.